Hello everyone, I'm Angela Evans, Senior Lecturer in Paediatry at La Trobe University. Today's lecture looks at the paediatric orthopaedic deformity of clubfoot or Talipes equinovarus, and with focus on the management technique of the Ponseti method. Here's a 4-year-old boy who lives in Bangladesh, born with bilateral club feet. Now this is a heartache for any parent anywhere in the world when their child is born with club feet, but the implications in the developing world are even more far-reaching, as without being able to walk and work, these children are usually even more impoverished. Here we'll just look at this little boy's gait, and you'll see why there's no controversy about the need for treatment for congenital clubfoot deformity. It's marked, isn't it? And clearly disabling if continuing to be neglected. Clubfoot doesn't get better with time, it just gets worse. And this is a 23-year-old fellow in Vietnam with neglected club feet. You can see the plantar surfaces of his feet have never borne weight. That's all transferred to the lateral side of the ankle, which is grossly distorted and painful at this relatively young age. This fellow was fortunate enough to get employment as a locksmith, and he rode to and from work on a motorbike, but already had significant pain with early onset arthritis. The etiology of clubfoot is interesting, and it's now thought that a combination of genetics and environmental factors are at play. Alterations and or deletions of chromosomes 2, 9 and 17 have been associated, meaning that this condition is often familial, certainly with a male predominance and usually bilateral. The environmental influences such as cigarette smoking, particularly maternally when a woman is pregnant, and also diabetes are associated with increased incidence of clubfoot deformity. There's quite a race on in the research genetic world to try and identify the loci of genetic factors. Chromosomal deletions and duplications that involve transcription factors notated as PITX1 and TBX4 have been found. Now these transcription factors activate genes responsible for normal limb development in the first 12 to 15 weeks of gestation. There have been and continue to be many etiological theories of clubfoot pathogenesis. Immobility intrauterine has been implicated. There have been neurological theories, vascular, and also the theory of connective tissue fibrosis. The vascular theory has had a lot of weight due to the fact that hyperplasia of the dorsalis pedis artery is found in 70 to 80% of clubfoot cases. There's very different reported prevalence levels across ethnicities, and this tends also to support a genetic cause. In China and Asia more generally, there's the lowest prevalence of clubfoot reported at around 0.3 to 0.4 per 1,000 live births. In the Caucasian population, so the developed world largely, the prevalence is approximately 1 per 1,000 live births. And in the closed genetic enclave of the Pacific Islands, the Hawaiians and Maori people have the highest prevalence, recorded as high as 7 per 1,000 live births for infant clubfoot. Across ethnicities, the ratio among male to females is always higher in male, at least 2 to 1, and in some of the populations higher than that. Classification of clubfoot is fairly straightforward. It's either typical or atypical. Most cases, fortunately, are typical, which occur in otherwise healthy babies, usually boys, and usually both feet. And this is approximately 70% of all clubfoot being typical. The atypical factors vary a lot in terms of severity and factors involved. Approximately a quarter of clubfoot cases are designated atypical. So these children have wider health issues, including conditions such as arthrogryposis, which we'll talk about in a moment, but this affects multiple joints. The muscles may be involved in terms of congenital myotonic dystrophy. There may be neural tube defects such as myelomeningocele, or there may be some auto-amputation in utero, as occurs with amniotic bands. There have also been some other genetic syndromes involved with atypical cases, such as trisomy 18 or deletion of part of chromosome 22. So this little girl presents with atypical club feet. You can see, looking at her feet, that there's been auto-amputation of a number of her toes or parts of her toes, and this occurred in utero, most likely due to amniotic bands. But if we look at her upper limb, we can see, at least on her right hand, that her little finger has also been partially auto-amputated. So this is not a typical club foot, and when a child presents with these features, we really need to look more broadly and particularly at neural tube. In this case, this little girl also exhibited significant craniofacial problems in the form of cleft palate and hair lip. Now these can be fixed surgically, but in the developing world this is often a little more difficult. So it's a tough start to life. Arthrogryposis, which I mentioned earlier, or arthrogryposis multiplex congenita to give it its full name, is a congenital neuromuscular disorder that usually affects multiple joints, restricting or at least limiting mobility. The limbs are most affected, and particularly distally, so the ankles and wrists. There may also be muscle weakness associated, and some muscles may be absent, so agenesis can be part of this. The hip joint may be displaced or at least displaced. If we look at the pictures on the right hand side, we can see that this is a little baby girl who is only 12 days old, presenting with a really unfortunate combination of not just club feet but arthrogryposis, affecting, as we can see in the larger lower picture, her hips and knees as well as the feet. So giving this very unusual presentation in a newborn of full leg extension. There may also, in conjunction with arthrogryposis, be facial deformities or wider spinal cord abnormalities, so these children need to be well examined by a paediatrician. And further, there can be disorders in other systems, respiration, cardiac, genitourinary, and even skin can have some disorders further. There's also what we now call a complex version of typical clubfoot, and this needs to be identified because of the treatment implications, and was first identified by Dr. Ponseti, the founder of the Ponseti method of management, which we will move to. The clinical features of this complex clubfoot are that it is occurring in an otherwise healthy child, usually a little boy, usually bilateral, but it's a much shorter foot, which is easier to identify in unilateral cases clearly as a comparison with the other side. The features too show that the first metatarsal is characteristically short with a hyperextended hallux, and equinus is marked, both typically of foot to leg, but also forefoot to rear foot. and there's usually a crease across the plantar aspect of the foot from medial to lateral. These feet are stiff. On a severity scale, they get a full score of 6. We think that the complex club feet approximate about 10% of otherwise typical types, and it is important that these are identified because the treatment needs to involve modification of the Ponseti technique if it's to be successful. So the clinical features of a typical clubfoot, the one that affects 3/4 of the children born with club feet, usually healthy children, is very much the retracted heel. These feet are in equinus at the rear foot. There's usually a crease on the medial side of the foot and a curved lateral border as part of the adduction. The foot can't usually be brought to plantigrade due to the equinus. If it's a unilateral case, the club foot is characteristically smaller and stiffer than the unaffected side, and there may be atrophy of the leg muscles as well. In unilateral cases, the affected leg may also be shortened, which has implications for management of limb length discrepancy with growth. The top right-hand side, you can see this child is halfway through having casts applied as part of Ponseti method of management, and we can see that the child's left foot, yet to be cast, takes on that typical club foot posture. It looks like a golf club, and hence the name. Whereas the child's right foot, already in a cast, you can see has much less adduction as part of the corrective phase. And the X-ray below shows certainly the equinus of the rear foot, but more notably the adduction of the forefoot through the midfoot. Difficult to see the varus. This cadaveric specimen shows all facets of the clubfoot deformity, the equinus, the cavus, and most clearly seen here is the deviation of the midfoot, and particularly the hallmark really is the medial displacement of the navicula on the head of talus. And we can see that the head of talus is only connecting with the navicular on the medial facet. The lateral part of the head of the talus is entirely uncovered. So cavus, adduction, varus and equinus. These are the 4 facets of the paediatric club foot which we address singly in theory but clinically simultaneously. These MRI studies are quite useful to look at what's seen in terms of surface anatomy versus images of the underlying skeletal structures. So we can see in the club foot here clinically that the navicular is medially displaced on the head of talus, leaving the lateral aspect of the head of talus uncovered, if you like. And so this is part of the adduction of the forefoot. We can also see, looking plantarly, that the cuboid is also adducted on the distal aspect of the calcaneus, and we can see with surface anatomy that the cuboid, being here on the lateral side of the foot, forms part of the adducted forefoot. If we look at the varus of the foot, which is a little more difficult to appreciate from the surface anatomy, we can see that the calcaneus is not only adducted but also inverted on the distal aspect of the tibia. So management of clubfoot deformity, and this is really part of what Ponseti has specified, was to break down each component of the clubfoot and address it sequentially to get the best outcomes. So the cavus is addressed by elevating the first metatarsal, the adduction is addressed by abducting the midfoot after the cavus is reduced. In doing so, as the midfoot is abducted, the calcaneus is everted, reducing the hindfoot varus. In turn, this tends to reduce the rear foot equinus, but usually this requires the involvement of minor surgery on the Achilles tendon to reduce the equinus adequately for gait. And just a reminder of the gait of neglected clubfoot. So the Ponseti method. Dr. Ignazio Ponseti was a paediatric orthopaedic surgeon who grew up and studied medicine in Spain and then moved to the Midwest after the Spanish Civil War. The basic treatment course for Dr. Ponseti's method for infant clubfoot involves conservative casting of the feet, with casts changed weekly for approximately 5 to 6 weeks to address each component of the clubfoot, as we've mentioned. Then at the end of that time, there's usually residual equinus still, which requires a percutaneous Achilles tenotomy to reduce the foot to a functional plantar-grade position for stance and particularly gait. So the feet are physically corrected at that point after 6 to 8 weeks. Then one of the differences compared to other casting techniques which have been cited for clubfoot management, the Ponseti method moves to a boots and bar splinting system to reduce the relapse of clubfoot deformity, which is part of its featuring, particularly early after treatment. So once the baby has corrected feet, they're moved into a boots and bar system continuously for 3 months, literally 23 hours a day. And then the splinting is continued to be used, but reducingly as the child gets older and starts to walk and mobilise more. But even so, it's recommended that the night splinting is used up until at least school age, when the relapse rate of clubfoot does diminish but still exists, which hence requires the monitoring of children who have undergone clubfoot correction at 6 to 12 monthly intervals through to skeletal maturity. So the Ponseti method, represented here pictorially, shows the initial clubfoot, stage 1, and the associated cast. So you can see that in the first cast, we really are just reducing the marked adduction, but the foot is still in equinus and, if you could see, still in significant varus. The next cast, or from the traditional Ponseti technique a week later, continues this corrective phase, and each cast replicates that through to the point that the foot is fully corrected, and usually requiring a tenotomy of the Achilles tendon to adequately reduce equinus for gait and walking. So again, if we look at some MRI studies, we can see that before treatment, the clinical presentation of the foot and the location of the navicular as opposed to the talar head. Through treatment, the navicular is moved laterally to increase the coverage of the talar head until after treatment or with full correction, there's no lateral aspect of the talar head palpable or uncovered. And similarly with the calcaneus and the cuboid, we can see before treatment with the marked adduction, varus, cavus and equinus, we can see that the calcaneo-cuboid joint is adducted, and then through treatment this improves, and to after treatment the calcaneo-cuboid joint is properly placed. The Pirani Severity Score, which I referred to earlier, is, as its name suggests, it's a scale for assessing the severity of the clubfoot initially, so before any treatment has been commenced. 6 is the most severe clubfoot, and 0 is a normal foot, which we try to achieve throughout treatment. There are effectively three aspects for which the infant clubfoot is assessed in the midfoot, and also 3 aspects for which the infant clubfoot is assessed in the hindfoot, making a total of 6 factors, and hence the Pirani score having a maximum of 6. We'll look at these in turn. So if we look at the rear foot signs, there are 3 of them, and we'll just look at the ankle equinus as an example of how the scoring works, but it's the same method applied for the empty heel sign and also the posterior crease. So with ankle equinus, 0, which is what we expect for a normal foot, we expect an infant newborn foot to have a high level, 30 or 40 degrees of ankle dorsiflexion easily available. In the clubfoot, this is always reduced. If we can manage to move the foot to 90 degrees to the leg, so just a plantar that's scored 0.5, so it's significantly reduced dorsiflexion on what we would normally see, but we actually are attaining 90 degrees. In the more severe clubfoot, the foot is plantar with full dorsiflexion force, so this is scored higher and gets the score of 1 for this sign. These are repeated, as I said, for empty heel and posterior crease, so that a maximum rear foot score for the clubfoot is 3 and a normal foot is 0. For the midfoot, again, there are 3 signs. The lateral border, which we're going to talk about, but also the medial crease and the talar head coverage, which are examined and scored in just the same way. So for the lateral border, which parallels to the level of adduction of the clubfoot, we can see that a normal foot doesn't have an adducted lateral border. The lateral border of a normal infant foot is straight. Here we can see that in this clubfoot there is mild adduction only of the forefoot, where the foot is just moved away from this straight object placed laterally, whereas over here in a more marked clubfoot we can see quite a deviation due to the adduction of the clubfoot away from the lateral border. So this one is scored 1. And again, the midfoot signs have a total score of 3, and added to the hindfoot signs gives a score out of 6 for the total Pirani score. The Pirani severity score has been found to be highly reliable between clinicians, which makes it useful for benchmarks and monitoring. And it's also been found to be somewhat predictive for the need of tenotomy. So the initial Pirani score before treatment, if the scores are 5 or above, these children have been found to nearly always require a tenotomy, so this can be predicted for planning and for knowledge of the parents. Scores less than 3.5 usually don't require a tenotomy, and again, this is something that needs to be addressed in every individual case, but it does tend to forecast the treatment course. So the Ponseti method as a mechanism for management has really revolutionised the way clubfoot is now approached across the world. 2 decades ago, the posterior medial release, a surgical procedure, was seen as the optimal treatment for infant clubfoot. But we now know that this isn't the case, and that better long-term results for lower cost are actually achieved with good application of Ponseti's method. How does this work? What is the actual mechanism or the mode by which Ponseti method achieves correction of clubfoot? There have been some histological studies that have looked at the ligaments of the clubfoot, and we know that the ligaments usually exhibit a crimped pattern and are expansile if tensile forces are applied at either end to effectively reduce the crimp and elongate the ligaments. this is in effect, in my very rudimentary representation of the ligament crimping, the essence of the Ponseti method with casting, such that the crimped ligaments are stretched with manipulation and held with casting to be able to uncrimp over time, which then allows for further elongation. So manipulation and through casting, the elongation, and this is repeated with the serial casting approach in the corrective phase. Whilst, as I said earlier, we tend to address the facets of clubfoot individually, the cavus, the adductus, the varus and the equinus, realistically the manipulation and casting it addresses these components simultaneously. We can see at the top picture here that on the skeleton the talus is stabilised and using the thumb placement, and then the forefoot is abducted around the stable talus. So without pronating the foot and enabling the navicular to be shifted from medial to lateral to cover the head of the talus. At the same time, as long as the calcaneus is not held and so is free to move, we can see that the abduction of the forefoot has the net effect of reducing the rear foot or calcaneal varus. And this is what happens through the casting process, with the equinus then needing the surgery intervention to reduce it fully in most cases. But this is percutaneous and a very minor procedure. So in each cast, there are 4 basic steps. And whilst we tend to focus on the cast as the corrective vehicle, we must remember that the correction is really achieved through the manipulation, which is manual. So it's our hands that achieve the correction of the infant clubfoot, and the cast just holds that corrected position, allowing for the ligaments to elongate, recrimp, and repeat from cast to cast. So it's always the clinician's accurate palpation and careful manipulation, which is usually held for a minute or so, that is the crucial part of every cast and underpins the correction. The cast is applied over firm padding to protect the skin, and again the manipulated position is then held whilst the plaster sets and moulded very carefully around the heel so that we maintain a good position and so that the cast doesn't slip. Once the below knee component of the cast is applied, which includes the corrected foot posture, we check to make sure that this is as required before then completing the cast above knee high up to the groin to stabilise it for the duration of the wear. X-ray studies have been looked at pre and post tenotomy of the Achilles tendon and have shown that the tibial calcaneal angle improves by average of 17 degrees. So we can see before the tenotomy, we can see that this child's foot, whilst corrected with clubfoot casting, and we can see good alignment of the forefoot in particular, the angle range of motion is only 90 degrees, and yet once the tenotomy has been percutaneously severed, which I think you can actually just see through the soft tissue shadow here, we can see that the dorsiflexion available is markedly increased. Often of concern to clinicians unfamiliar with the Ponseti method and or parents is the issue of the rejoining of the ends of the severed Achilles tendon, but this has been confirmed to happen within the first 2 weeks post-surgery on sonographic studies. So importantly, after the correction of the feet using the Ponseti method, manipulation, casting, then the Achilles tendon, tenotomy, which is held in a further stabilising cast, the feet look corrected. The parents are usually very happy at this stage, but need to have been informed from the commencement of treatment as to the very important role of the maintenance brace if we are really to get a long-term result for their child. As I said earlier, once the feet are corrected, they're placed into this abduction splint full-time for 3 months, 23 hours a day. Night-time to school age, longer if possible, so often incorporating daytime naps. And normal footwear is used during the day, time with no splint use other than naps. And then it's always important to be encouraging the parents and the child as they get older as to the importance of the bracing, because without good bracing use, numerous studies have shown that the deformity is likely to recur. And in fact, as many as 80% of relapse cases after initially good correction have been attributed to insufficient or inadequate use of the maintenance brace. So clearly we need to support and educate the family right from the start. It's no good springing the brace onto the parents in what can seem like an adjunct form of treatment after the casting process. The brace needs to be seen and shown to the parents right from the very first consultation. It can take a baby and the parents a few days to get used to the brace, but remember, in a young baby in particular, they have been used to having casts on their legs, so a brace is perhaps not quite as intrusive as we may think. Certainly the younger babies do adjust more easily. Often parents are very worried, and if it's not parents, it may be well-meaning grandparents, are worried and just don't understand the need for the brace. They think their child's feet look fine, so why do we need to use the brace? But this needs to be explained from the very beginning, that the relapse rate is very, very high without adequate use of the brace to school age and often beyond. I'd like to talk to you now about a project I've had an involvement with over some years, which is called Walk for Life, and the website is here for you to seek further information from should you wish, which is the Sustainable Clubfoot project in Bangladesh for the management of infant clubfoot. And this is a little girl, Yasmin, with before and after treatment photos to just illustrate the capacity that the Ponseti method, well applied in a developing country, has for improving the lot of a young child who becomes a young girl and later a young woman. So Yasmin, as we can see on the left, was born with bilateral club feet. After treatment, her feet are corrected. She's still wearing the boots and bar, but she is in a good position as her motor development advances to be ready for walking and running and playing like a normal little girl. This is a happy story about the use of Ponseti method through the Bangladesh Sustainable Clubfoot program. A little story about Sazim, a baby boy. And Sazim's father had said to his wife, "You know, if my son's life was normal, I would feel like touching the moon." After treatment with Ponseti method, he'd had this realised in his life, where he said, "I have the moon right in my arms now because Sazim's feet had been corrected." And this was because of referral to a Walk for Life clinic, where one of the senior physiotherapists, Sakina, who the parents regarded as their angel, had undertaken correction of Sazim's feet using Ponseti method, which makes clearly a difference for the life of the child and also the contentment of the parents, who very much realise the likely poverty and disability that clubfoot untreated will engender for their child. The contemporary Ponseti method is basically the traditional Ponseti method as it's been advanced and changed with more recent research findings. We now very much acknowledge the differing types of club feet, typical versus atypical, and the complex clubfoot as a subgroup of the typical clubfoot. We may well find with genetic research advancements that there are further subgroups as well. Overall, we tend to use a longer manipulation time than was first recommended, because this is the true corrective modality, that manual correction of the infant clubfoot, abducting the foot around a stabilised talus and allowing for the ligaments to decrimp. We have found that reduced casting time is possible and yet achieves the same correction. Initially, this work from Mokyonde, who was an associate of Dr. Ponseti, found that there was actually no difference in the corrective results of the clubfoot when a cast was left on for 7 days or 5 days, but clearly that can be better for the baby to have less time in plaster. More recently, 2 randomised controlled trials, one in China and one in the UK, actually found that casts could be changed as frequently as every 2 to 3 days without reducing the correction of Ponseti method casting, and this has great implications for almost halving the amount of time a baby is in plaster and halving the corrective phase of treatment. The tenotomy is nearly always advisedly performed under local anaesthetic, not with general anaesthesia, and the realistic bracing times have become more commonplace, particularly once a child starts to mobilise. The use of normal shoes for daytime and using the brace for sleeping has been adopted rather than was what perhaps originally a little more stringent. With a large outcome study in Bangladesh, we are possibly more realistic about outcomes as well, and it seems that the Ponseti method generally gives very good results in 70 to 80% of cases where it's well followed through. But clubfoot is not a predictable or homogeneous entity, and the genetic basis of that, as it's being explored, will probably provide us with even more information that will help to guide assessment and treatment. The prevention of clubfoot per se is not at this stage possible. What we can do, however, is try to address the factors that have been shown to be associated with an increased incidence of clubfoot, so smoking during pregnancy, overweight and obesity, which tend to result in higher rates of diabetes. Possibly avoiding conception in June for people who are more predisposed to clubfoot, say with a strong family history, may reduce the influence of the enterovirus, which has been implicated. Vitamin supplements have been proposed but not at this stage proven, and the possibility of genetic snipping to actually remove loci associated with clubfoot deformity is a future possibility. So this has been a basic overview of infant clubfoot deformity, its pathogenesis, and particularly its anatomy and management with the Ponseti method, but you're referred to some of these suggested readings to inform you further. Thank you.